Howdy, I'm live. Good Sunday morning, everyone. Aaron Boster here. Thanks for learning about MS with me. It is Sunday, almost 9 a.m. and Eastern Standard Time. I wanted to jump online with you guys, see who is online, see if anyone wanted to have a cup of coffee, and maybe talk a little bit about MS. Pink Meadows just showed up. Pink, hey, how you doing? Welcome. As folks roll in, please make sure you share where you're coming in from. So type in your location. It's really awesome to get to see where everyone's coming in from. Hello, Cindy. Great to see you. Hey, Jojo. How are you? This is fantastic. I'm going to give a few minutes to let some people roll in. If you're excited about this impromptu Ask Me Anything live stream, definitely throw a thumbs up. Let me know that you're into what we're doing. And Pork Barrel Investing is in their house. I wonder where your house is. Greg's in California. Helen is on from the UK. Pink is in Chicago. Jojo's out in Zanesville. We've got Caesar on the line. Hello. Howdy, Christy. Hello, Anne. Hello, Cindy. We've got folks from Switzerland. This is really fantastic. I'm loving this. Karen Tweed is on the line. John is here. John, it's great to see you. I hope you and yours are well. Rochelle is here. This is fantastic. I'm going to take a few moments and let folks roll in. Aid is calling in from the UK. That's always exciting. I've got Dominic here from Istanbul. That's fantastic. Jessica's down in Florida, loving her weather. Kyle is in Springfield. I'm digging that. Tracy is online, and the pill is here. So as you jump online, please make sure you're typing in where you're coming in from. I love to go back through the chat later and hear where all of you are amassed in this global online community. That's really fun for me. If you like what we're doing, definitely give it a thumbs up. So you can hit the thumbs up button on the YouTube algorithm. It really likes that. And if you have questions, fire them away. So there's a question up here from the pill. I'm thinking of switching from Ocrevus to Kesimpta. Good choice? Question mark. Both of them are B-cell killers. So they're both B-cell depleters. So mechanistically, they work very, very similarly. I would even go as far as to say it's kind of like Pepsi and Coke from a mechanism standpoint. Ocrevus is an infusion twice a year, and in my biased opinion, there's an upside to that because in between, you don't have to do anything. You don't have to remember to give yourself a shot. Oftentimes in my center, we do the Ocrevus infusion with the clinic visit. And so I say, well, let's just do MS twice a year. Kesimpta is not a bad option, particularly for people that want to go on a B-cell depleter, but they can't travel. And so I think that between Ocrevus and Kesimpta, there's probably more similarities than dissimilarities, and there's preferences, but I don't know that making that switch is a big change. To me, that's in some ways a bit of a lateral move mechanistically. Great question. Thanks for asking it. So let's get caught up here. We've got a bunch of people that have jumped on. There's 53 of us this morning. Aid from UK writes in, hi, doctor. Well, hey, Aid. Can testosterone be a good treatment for men with MS alongside medication? Aid, absolutely it can be. If you search on my channel, I have at least one, if not two videos on low testosterone in men with MS. And the deal is pretty straightforward. If a guy with MS has a low testosterone, he's at higher risk for cognitive impairment, difficulties in the bedroom, also fatigue, and faster progression of neurological disability in MS. And so that's a lot of bad stuff. And if you supplement testosterone, it looks like you can improve that. And so recently in my clinic, we've been checking all men levels of testosterone. And if it's low, we're doing a workup, sending them to urology. We're getting them treated with testosterone to improve all of those things. So it's absolutely worthwhile looking into. Yes, it is in addition to a disease-modifying therapy. People are still jumping online. This is fantastic. There's 64 of us. Again, if you are just jumping on, please type in where you're jumping in online from. I love to read that. Joe Siders is on. Joe, hey, how are you? Aaron Reed is calling out from North Carolina. A lot of great folks are jumping on. So next question. There's someone from Siberia. That's really cool. And Marija, and they write in, what is your opinion about the Coimbra protocol, high-dose vitamin D as a treatment for MS? So I'm not sure that I would adhere to that specific protocol per se, but I do think that low levels of vitamin D increase the risk to develop MS. And I do believe the data that suggests that low levels of vitamin D drive MS disease activity faster. So pushing the level up is a really good idea. We want it above the number 50, but below the number 100. So anywhere in the range from 50 to 100 is where I'm shooting for. Oftentimes I can accomplish that by taking over-the-counter vitamin D3 daily, or by giving prescription strength once weekly. So that's a great question. And I definitely think that all people impacted by MS should drive their vitamin D levels up above 50 as it slows the disease down. So the next question is from Caesar. I'm thinking of switching from Aubagio to Ocrevus because now I am transitioning. Wait, where? Oh, darn it. I think I lost it. Transitioning from rrms to secondary progressive MS. What do you think? So Aubagio is a pill that you take once a day for MS, and Ocrevus is an infusion twice a year. And I think that there are some, from a potency or efficacy standpoint, I don't really think there's a big comparison. I think Ocrevus stands out above it. Why would someone take Aubagio? Well, there's lots of reasons. In fact, I did an entire 20-minute video on this channel about why someone would consider Aubagio. If you're talking about efficacy, particularly efficacy related to relapses and new MRI lesions, Ocrevus is going to win. If you're talking about de-escalation and decreasing risk, then maybe Aubagio might win. And so I think that there's a lot of specifics about your situation, Caesar, that we would have to understand that I don't know right now. Now, do I think it's necessary to switch from Aubagio to Ocrevus because of a transition to SPMS? I don't know that that's the reason that would drive my switch, but it is an escalation of therapy, and I don't think I would shy away from it. Let me know what you end up doing. So let's see, Karen is on. Meeting a new neurologist for the first time later this month. Any advice, questions that I should ask? So Karen, I have a YouTube video on this channel where I talk about what you should ask your neurologist or how to prepare for your neurologist visit. I think that's actually the name of the video. So do a search on my channel for how to prepare for the neurologist visit. There's a lot of things that you want to do to get ready. So let's just talk about them for a few minutes right now. First of all, you want to make sure that you know how to get there on time. And I would plan on being about at least an hour early, because invariably they're going to have a bunch of paperwork for you to fill out. At my center, we ask the patients to do about an 11-minute series of questionnaires online. It's on the electronic record. And then there's also some validated testing. So get there an hour early. It's going to really make things not rushed. When you go, I would go with somebody. Karen, so if you can bring a friend with a set of ears, just so that they can listen and help take notes, and that depressures yourself as you try to get to know this new doctor and try to navigate through the logistics of the visit. Wear clothes that are loose fitting. And so if they're going to do a neuro exam, you don't want to be wearing really, really tight fitting clothes, multiple layers of sweaters, for example, that you'd have to peel off. So wear loose fitting clothes that are easy to be examined in. Bring a list of all of your medications. And if you can't do that, bring the bag with all the bottles in it so that we know exactly the medications you're on, the doses, the schedule, etc. So bring that up-to-date list. I would also recommend bringing any old clinic notes that you have collected from old doctors. Bring all the old documentation. And I would bring every old MRI that I had. I actually request that families do this prior to when I meet them so that I can review it ahead of time. But if you're meeting them and they haven't reviewed that, I would bring all that stuff. I would also recommend writing down my past medical history, so all the current conditions that doctors treat me for, any old surgeries I've had, any allergies that I've had, and any illnesses that tend to run in my family. I would write all that down because the doctor's going to ask you those things. So you can have it ready for them. You could even give them the paper potentially. I would write down a list of questions of things that are important to you. And those might be a question about MS. It also might be a question about how the clinic works. How do I get a hold of you? What do I do if this happens? What do I do if that happens? How do I get a refill? And that's important. So there's a lot more that we could talk about to get ready for a doctor's appointment when meeting a new neurologist, but definitely check that video out on this channel. So there's 112 of you that have jumped online. That's fantastic. There's only 37 likes. So if you're watching this right now and you dig what we're doing, definitely give it a thumbs up. So we've got folks from North Carolina, from Urbana, Ohio, from Israel. That's really awesome. So I'm going to mispronounce this name, darn it. Aditi writes in, hi, I'm from India. Hello. What are the treatment options for relapse-free progressive MS apart from rituximab or another anti-CD20 therapy? So that's a great question. It's a complex question. So in the United States of America, we have a label for drugs with relapsing MS, and there's one drug that's labeled for primary progressive MS, and that's what you're discussing here, anti-CD20 therapy. And the best evidence for slowing progression of neurological disability in PPMS is with an anti-CD20, with ocrelizumab. And so it makes good reason that if somebody has PPMS, we would want to use a B-cell depleter, ocrelizumab or rituximab off-label, or even Kesimpta as a B-cell depleter that theoretically might work in that space. Now, here we're talking, in this question, you say relapse-free progressive MS. So I'm assuming that you mean PPMS. If you're talking about secondary progressive MS, that's someone who has had attacks at some point, so they have a relapsing form of MS, and they're still at risk for attacks. And now they're having progression independent from attacks. And that person, in my mind, has more options for what's available to treat them. Amy Welsh is on. She says, hey, Doc. Hey, Amy, how are you? New Philadelphia here. Awesome morning in Ohio. I agree with you. Dana writes in, is it common to have mouth numbness in MS? Or is it normal to intensify when I'm out in the heat? It's spread over my left side of my face and nose, even my ear. So, Dana, you point out a couple things. And MS can affect anything in the supercomputer or the superhighway. So, can MS cause mouth or face numbness? Yes. Is it common? I don't know that I would call it common, but I certainly see it. And then you also point out that symptoms can intensify when you get overheated. Now, that's very, very common in MS. And so I'm not surprised to read that from you. It's my hope that if your body cools down, that gets better. And so I would be very curious if you wore a cooling vest outside, whether that happened, or if you could cool your body down by, drinking ice water, or even using that medicine Ampera for aminopyridine. I would be curious if that would protect you from the heat sensitivity. By the way, MS Water Challenge guys, drink up. So Christina writes, every day I am getting a lot better and even more since the gut started working. I'm not really understanding that question. Someone's from Tulsa, Oklahoma. Tracy writes in, you're not on my new insurance, CareSource, MyCare Ohio. If you get the credentials, that would be great. So Tracy, as a matter of interest, I actually am involved. I am on network with CareSource. We have two business entities, and Levy Therapeutics is in network. And so I do see patients with CareSource, and I can take their insurance. On the Levy side, we're able to do everything that we need to do. So if you're listening to this and you have CareSource, don't think that you can't come see me. Call the clinic and ask, and we'll explain to you the mechanism, how we do it. So Little Rocky writes, I'm happy to be here with you. Well, Little Rocky, I'm glad to be here with you as well. It's fantastic connecting people in this forum. I love this growing global online community. If you guys like what we're doing, throw a thumbs up. Let's try to get that thumbs up number up near 100. So someone writes in Holland, what do you think of the drug Ozanimod? So Ozanimod is a Gilenya Me2 drug. It's a second generation S1P receptor. Ozanimod has an upside that you don't need to do a first dose monitoring. You can titrate by taking the special pill pack. Ozanimod has good efficacy with relapses and new MRI lesions. I'm disappointed in Ozanimod's ability to decrease progression of disability. It's not better than Avonex, and that leaves a bad taste in my mouth. Now, interestingly, the question right before that from Luca is about Siponimod, which is another Gilenya Me2 drug. That's Mayzent, and I can make the same comments. It's a little bit easier to start Siponimod than Gilenya. You still have to check some lab tests, but you don't have to do a first dose monitoring. And again, Siponimod is an okay medicine. I think all of the class of medicine leave a little bit to be desired as it relates to progression of neurological disability. I have a bias against using S1P receptors in patients as they get older. I think that there's an increased risk for side effects there, and it's something that I avoid when people get above 50 typically. So Edward writes in, I wanted to thank you for talking about testosterone and MS. I discussed this with my neuro, and we had mine checked, low 200s, which is low. Is this a value that I should discuss with my neuro PC urologist? Yes. So anything under 400, I'm going to talk about treating. And so 200 is definitely on the low side. And so I would definitely recommend talking to your doctors about that. Ren E. Berry writes in hearing loss. Someone else asked if it's caused by MS. I echo that question. I'm convinced mine was caused by MS. What do you think? So you can have hearing loss from MS. It's actually very rare. It's hard to have hearing loss bilaterally because you have to have damage on two different parts of the brain in the exact right spots to have no hearing in either ear. But that can happen. I have seen that. I haven't seen more often people where they lose hearing in one ear. Good question, though. So Amber writes in from New Jersey, any tips on tremors? Tremors are hard to treat, actually, and it depends on what kind of tremor. So there's a lot of different kinds of tremors. There are pills for those ills. Some of them are more effective than others, but we would need to know more about the kind of tremor. Is it an intention tremor? Is it an action tremor? Is it a tremor at rest? How big is the tremor? Then we would have to experiment with some medicines to try to decrease the amplitude. One quick tip that sometimes helps for a tremor is a weighted bracelet. So let's say that your hand is tremoring and you have a weighted bracelet on it. It's going to weight it down so that it doesn't tremor so much. And sometimes that can make a big difference when trying to do something like pick up and drink a cup of coffee, because the weighted bracelet makes it so your hand doesn't shake, and that way you can hold the coffee. All right, so Janelle writes in, do you take UPMC for you? I've been trying to get a second opinion everywhere. So I think the question is, do I take an insurance from UPMC, which I'm assuming is a product in Pennsylvania? It depends. I probably don't have Pennsylvania insurance on our formulary, but you may have out-of-network benefits. And I've seen a lot of patients from out of state, and their insurance has what we call out-of-network benefits. So they're allowed to come and see an out-of-network doctor because their insurance accommodates for that. So you can call your insurance company and ask if you have out-of-network benefits, or you can just call our center. I'll even put the number down here, 614-304-3444, or you can check us out at bosterms.com. And I just put that in the chat. And then we can check with you and figure out. And if you have out-of-network benefits, we can schedule an appointment. I've seen a lot of people from Pennsylvania this past year. So let's see what other questions are cooking. So we've got a question here. How do B cells repopulate after Ocrevus? Are there any triggers? In my case, rrms, healthy, doing exercises, they already come back at 5 months. I know some people take 7 to 8 months. So when you take Ocrevus or Rituxan or those medicines that deplete B cells, they do just that. They knock down populations of B cells, but they don't kill the stem cells, the baby cells, the pluripotent stem cells that will then grow up. And it takes 6 months on average for those cells to grow up, which is why Ocrevus is dosed every 6 months. Because on average, 6 months later, the baby B cells have grown back up, and then you want to kill them also. Now, some people, they repopulate sooner, and it sounds like you repopulate sooner. And some people repopulate slower. And there was an article, or not an article, but there was a poster presented at AAN a couple years ago, pre-pandemic, which showed that if you were a larger human being with a larger BMI, that you may repopulate your cells sooner, so it kind of wears off faster. And that if you are a smaller human being, it may last longer. But I've seen that be the case even without people that are particularly big or particularly small. Everybody's an individual. And right now, some neurologists dose Ocrevus or Rituxan by checking anti-CD19 levels. There's some difficulty in doing that, actually. In an ideal situation for you, we would be giving you Ocrevus a little bit sooner. Unfortunately, the American FDA doesn't allow for variability in dosing like that. And sometimes what I end up doing is I end up giving people a slug of steroids a month before their Ocrevus, just to tide them over to get them to their next infusion. So Austin writes in, sorry to ask you again, any information on MOG positivity antibody? So MOG, myelin oligodendro glycoprotein, MOG, is it's an epitope on myelin. So it's like part of the myelin proteins, right? And you can develop autoantibodies against it. And if you develop autoantibodies against MOG, you can have a syndrome called MOG antibody syndrome. And typically it presents as recurrent optic neuritis. I've also seen MOG that looks a lot like NMO. So it's kind of, in my mind, in that NMO family. It's its own condition. It's got its own antibody. You can test for it. There's a lab for it. And you can treat this. And so we typically treat MOG positive antibody syndrome with medicines like rituximab. And I've had great success over the years doing that. We used to call it CRION, chronic relapsing inflammatory optic neuropathy. That's a handful. But we now know that those patients, when you test them for anti-MOG, are anti-MOG positive. It's a cousin of multiple sclerosis, and it's treated with very similar medicines. So High Road Intuitive Tarot writes in, I'm getting ready to get a cervical MRI. Have you ever seen lesions on the cervical spine and 0 on the brain? Yes, I have, many times. So Starla writes in, Dr. B, what are your thoughts on Tecfidera? So Tecfidera is a pill for MS, for relapsing MS, taken twice a day. It's a fumaric ester, and it works in a neat way. It makes your cell think it's under oxidative stress when it's not. And so it causes the cell to release a cascade of antioxidant loveliness, which quells MS. And it's a moderately effective drug. So it's got moderate efficacy. It's not a low efficacy drug. It's definitely superior in my mind to the first line shots, but I don't think it's a high efficacy drug. And it's a twice a day pill, which is kind of a pain in the tush. And it has side effects of facial flushing and sometimes GI upset. And so it's not a drug that I reach for personally very often. There's nothing wrong with it. I just think that there are better, higher efficacy drugs out there. That's just my own personal opinion. So I'm going to say this name wrong, and I'm sorry. Maraja writes in, is low white blood cell count related to MS? What are your opinions based on your extensive experience? So having MS does not cause your white count to be low. Taking MS medicines can cause your white count to be low. And actually, many of the MS medicines, either on purpose or by accident, can drop your white count. So Copaxone doesn't drop your white count. Tecfidera does about 20% of the time. Aubagio does only a tiny little bit. Gilenya drops your white count, moving 80% of the cells into the lymphatics. So Tysabri does not drop your white count. In fact, your white count goes up a little bit. Rituxan and Kesimpta and Ocrevus, they all can drop your white count. Mavenclad can drop your white count. Lemtrada can drop your white count. My point here is many of the MS drugs can do that, but not MS in and of itself. So the next question comes from Dojna Cutters. And if I say your name wrong, I apologize. It says, what is a normal average range of lesions in a year for relapsing MS without any drugs? It's variable for individual, but back when I was in training and the drugs weren't very good, we would accept one new attack a year or even one new spot a year. Now, that's completely unacceptable now, but back then the drugs weren't very good. How many, I would really not like to find out how many new spots per year that you could acquire off drugs. That's a scary thing because those spots are actually brain damage. And so I don't want you to have brain damage. So we've been doing this now for about 23 minutes. There's 138 of you online, which is awesome. Happy Sunday. My name's Aaron Boster, MS neurologist in sunny Columbus, Ohio, founder of the Boster Center for MS. And I'm enjoying spending my Sunday morning drinking a bit of coffee with you and answering your questions about MS. If you're just jumping on and you're digging what we're doing, definitely leave the chat just to give a thumbs up, then jump right back in. Let's try to push that thumbs up to 100. We're only at 89. Come on, guys. I know that we can do it. So Helen writes in, itchy inner ear, left side only. Could this be MS? Nothing seems to help. So yes, it could be from MS, and that can be a form of neuropathic pain. Some people don't know that itching is a form of neuropathic pain. And unfortunately, it can happen in MS, and it's very, very frustrating. The good news is there are lotions and potions and pills for those ills, and we might be able to use neuropathic pain medicine to make that better. All right, so let's see here. Here's a question from Adriana, who writes in, how do you differentiate MS lesions from mini strokes? I probably have both due to a heart condition recently diagnosed with AV block, which is the safest medicine for heart. Greeting from Costa Rica. Well, howdy. So you can tell the difference between a stroke and an MS lesion on the MRI based on the way it looks. So that's one way. Also, by taking a careful history and listening to the way the symptoms occurred, that's another way to separate it. And I can't give you a recommendation for the best heart medicine because I don't have enough information. Fortunately, there's a gazillion medicines to address heart and AV block in specific, and so it's my hope that you can work with your doctors. Probably need to make sure that your cardiologist and that your neurologist are talking so they can make sure that the medicines play nicely together. So next question, Callie writes in, why might a neurologist list MS on the diagnostic paperwork, records, etc., and then say they aren't actually sure? Why not wait before listing it officially to be sure? And so that's actually a very good question. Sometimes when a patient is referred to me, they're referred for a question of possible MS. And so as I'm ordering tests, I might write rule out MS on the MRI because I'm trying to tell the radiologist, please look for possible multiple sclerosis. A more formal way of doing it is not to put possible MS, but to actually put the symptoms that you have. So alternatively, the neurologist might write MRI to evaluate numbness and ataxia. And so sometimes the doctor might write MS because they're working up MS, but that's really, really confusing. And it might be more appropriate to code that on the notes as demyelinating condition not otherwise specified, or some other like less confirmatory diagnosis. And you can ask the neurologist about that. And I'm wondering whether they may say, hey, that was just my working diagnosis. And that may be what's going on. Austin writes in, thank you for answering. Oh, you're welcome. Dominic writes in, I do this CD19 dependent Ocrevus Infusion. They check my CD19 levels every 2 weeks. So when you take a medicine like Ocrevus or Rituxan or Kesimpta, you deplete cells that express CD20. But you can't measure CD20 if you take a CD20 depleter because it messes up the test. And so you check CD19, which tells you the same information as CD20. So presumably by checking the CD19 level, they can see how much they've depleted your B cells. I do not adhere to checking it every 2 weeks. In fact, that's not a style that I like to participate in, but apparently some doctors do that. And the idea behind it would be we can tell you when it starts to climb and then we can redose you. Jane writes in something about a chair for urinary incontinence. I'm not familiar with that chair. I'm sorry. So Firefly, and by the way, that's a cool name, Firefly. Firefly is an amazing show. It was a very short series, kind of a Western in space. I loved it. And in fact, one of the main characters on Firefly was named River Tan. And that's how we named my dog River after that show Firefly. Because River Tan was this like badass, cool gal. She was a martial artist and really, really tough. And so my kids really liked her. And so we decided to name the dog after that awesome female character. So Firefly writes in, good morning, Aaron. Well, hello. My chickens and bees say hi. I have loaded one. Which interventional clinical trial do you recommend for those of us without any healthcare treatment? So if you don't have access to healthcare, then we still want to treat you for your MS. And if you don't have insurance, let's say, there are still many, many options to get treated. And oftentimes, pharma companies, at least in the United States, if you don't have insurance, they'll give you the product for free. And so you may literally talk to the neurologist, say, I don't have insurance, but could you help me apply? And because I don't have insurance, maybe there's assistance programs where I can get the medicines at no cost. Another option is to go into a clinical trial. And I have certainly had patients who didn't have access to insurance, let's say, and they've gone into a clinical trial. Which is the right trial? I would say a trial that does not have a placebo arm. So the way that we run MS clinical trials in 2021 is a patient goes into the trial, and I'll give an example of a trial that I'm currently running, looking at these BTK inhibitors. So we're studying two different BTK inhibitors, fenobrutinib and tolobrutinib. And in both of those different trials, patients on the trial are receiving a pill, and it's a real MS pill. It's either the BTK inhibitor or it's Aubagio, which is the active comparator. Now, the person on the trial and I don't know which one they're on. It's a blinded experiment, but the thing is, we know they're on a real drug. So here in the context of the trial, they're getting a real MS medicine, and it's free to them. And they're getting access to MS clinic visits with us and labs and MRIs and all those things. And they're getting healthcare, and it doesn't cost them anything in exchange for not knowing which of the two drugs they're on. Now, at the end of the trials that I'm describing, they go for about 2 or 3 years. And then when the trial is done, they unblind. So we say, you were on this or you were on that. Then oftentimes the people that have made it through the trial are then allowed to continue to take the study drug for free, and it's called open label, where everyone knows it. And that's another really cool opportunity, because then that same person stays on drug for years for free. And I think that is a viable option. It's the best option for someone who wants to fight back and stick it to the disease and participate in research, but doesn't want to risk being on a placebo drug or not being on anything. So Dana writes in, yes, my lymphocytes were real low last blood work. My neurologist said I possibly would have to take my Mayzent every other day. Will that cause me to possibly have a relapse? So there's a couple things about that I want to unpack. First of all, the way that Mayzent works is it moves 80% of your white blood cells out of your bloodstream into your lymph nodes. So then if you take a needle and stick it in your arm and draw red blood and look at the cells, you'll say, there aren't very many cells. But that's on purpose. That's because you moved the cells into the different container, into a different compartment, into the lymph nodes. So it's not appropriate in my mind to say, oh no, the cells are too low, and then to take it less often. That's actually the way the drug is intended to work. And in my opinion, I would not go every other day. When you go every other day, there's a risk that you can have breakthrough disease. And so that is not something that I would recommend doing. Let me keep looking here. I had other questions. Yvonne writes in, I have read that metformin can help regrow myelin. I'm on Ocrevus and on metformin. What are your thoughts on metformin? I think metformin is fascinating, and I have started to talk to a couple patients with primary progressive MS about maybe taking it. And a couple of them, we've prescribed it. It looks like it may help with remyelination. It looks like it creates a state of near fasting in the body, and that seems to help with MS. It's not prime time. I can't say that it's a class 1 recommendation, and I can't even tell you that I'm doing it with lots of patients, but I have started to experiment with it a little bit in clinic with some people. And so I think it's really cool that you're on that. And I think it's something to keep in mind as we move forward. It may be something that I do more and more. Sandra writes in, this past year has been so stressful teaching. I have had vertigo, MS hug constantly. My foot was dragging. I couldn't sleep. I just can't do it anymore. My administration is not helpful. And Sandra, that stinks. And I'm sorry to hear that. And you bring up the real life experience of someone trying to live their best life, trying to work as a teacher, and having multiple sclerosis. And simply put, it can be really, really challenging. And so I think going to the administration, asking, for example, for a reasonable accommodation, for example, having your classroom on the first floor, not the third floor, are things that you can ask. And if you're part of a union, you can definitely ask the union to help come support you. You can ask your doctor for a letter of medical necessity. There's a lot of ways of working with your employer to help them understand, hey, look, you are a rock star employee. You're trying really hard. You just need some accommodations because of your condition. Jennifer Crookshank writes in, hi, doc. Hey, Jennifer. I'm having terrible side effects from Tysabri. Have you ever reduced the dose to eliminate side effects? Jennifer, I've never reduced the dose. I wouldn't want to reduce the dose of Tysabri. I have given pre-medicine to help with side effects, and I have spaced it out. And sometimes that works, and sometimes we actually have to leave Tysabri if it's truly untenable. So there's 150 of you on. That's just awesome. We've been doing this for half an hour or 33 minutes. It's Sunday morning, and I'm loving having some coffee with you guys and taking your Ask Me Anything MS questions as we chat about multiple sclerosis. All right, so do you recommend getting the COVID vaccine before starting Ocrevus? 100% yes. I 100% want you to get the COVID vaccine, period. And if you're going to start Ocrevus or Kesimpta or Rituxan or Gilenya or Siponimod, Mayzent, Ozanimod, or Ponasoy, any of these S1P receptors or any of these B-cell depleters, I 100,000,000% recommend getting COVID vaccine before you start. Because after you start, there's some emerging evidence that the vaccines don't take as well. And so you want to get vaccinated before you start, ideally to help you mount a full immunity before you go on that really effective therapy. What are your thoughts on CSF positive only for myelin protein, but negative for everything else? All MOG and other tests were negative. MRI negative, symptomatic lower body foot drop. So when we talk about positive spinal fluid, the only thing that counts for MS is oligoclonal bands and IgG index. So if the CSF protein was elevated, that doesn't mean anything towards MS, and it doesn't contribute to the diagnosis. The white count, we see trends, but really the CSF positive results are unpaired oligoclonal bands or an elevated IgG index. And I wouldn't interpret anything else. Now, if you had positive bands, but a normal MRI, I don't think that we can make the MS diagnosis. And if you have a normal MRI and normal findings on exam, it's going to be really hard to make an MS diagnosis, even with positive spinal fluid. And so that might be a situation where we, A, need to look elsewhere for another cause of your symptoms, or B, we may need to follow you with serial MRIs to see if something evolves on the MRI later that helps us diagnose you. Helen writes in, ocrelizumab and COVID vaccine. I've had very poor antibody response to the AstraZeneca. Is this normal? Helen, the data that's emerging suggests that many people with B-cell depleters like Ocrevus don't mount a full B-cell response to the COVID vaccine. Now, we assume that you mount a full T-cell response. And the thing that we don't know yet is that enough? It might be enough. And so we're very eager to find out, and there are studies ongoing which will soon report out on this. Someone with MS on Ocrevus or Rituxan or Kesimpta or what have you that get the vaccine and they don't mount a full B-cell response, but they mount a T-cell response, is that good enough? And stay tuned, we should have those answers very, very soon. So can you explain the 5 rules we need to keep in mind when living with MS? Could be helpful to new listeners. So Inan writes in, they're talking about my 5 for 5 in MS. And so when I want you to think about managing your MS, I want you to think about it in 5 categories. There are 5 things that I think that every person impacted by MS should do. And so I want you to be 5 for 5 in your fight. So let's go through all 5. And if you're listening right now, type in the chat if you're 5 for 5 or maybe 4 or 3 for 5. So number 1 is to not smoke stuff, because smoking speeds up MS by about 50%. And if you don't have MS and you smoke, you increase the risk to develop MS by about 50%. And when I say don't smoke stuff, I mean don't smoke tobacco and don't smoke marijuana. I am a medical marijuana recommender, by the way, and I think that MMJ is very, very helpful for some MS symptoms, but I don't recommend smoking it. I recommend using edibles or tincture or topical or vape, but not smoke. So number 1 is don't smoke stuff. Now, we could extend that to include other cardiovascular risk factors, things like controlling diabetes and high blood pressure, morbid obesity, inactivity, etc. Number 2 is to supplement low levels of vitamin D. So we want the vitamin D above the level of 50, below the level of 100. And we normally get vitamin D from the sun. And it's really hard to get sun in Ohio in the winter. And so most of the time we take a pill. The best way to get vitamin D, however, is to go shirtless for 15 minutes outside. That'll give you about 5,000 international units, and that's free. And there are probably other benefits to sun. Now, when you talk about number 2, supplementing vitamin D, we also could extend that to talk about diet in general. And I have a lot of comments about diet, but let's keep it simple for right now. Number 3 is to exercise as part of your lifestyle. Now, that does not mean that you need to become a professional MMA fighter or that you need to climb mountains. It does mean that we need to find an activity that you can do on a regular basis, a couple times a week, ideally, so that you can have a lifestyle that involves exercise. Number 4 is to take an MS medicine and make sure it's working. And so I want you on the most effective MS medicine that you're comfortable taking. And we need to make sure it's working by examining you in clinic, by checking MRIs, and by talking and listening to you about whether you're having progression of neurological disability, whether you're having attacks, or whether you're failing the litmus test of life. Number 5 is a recent addition. I used to talk about being 4 for 4. Now I talk about being 5 for 5. Number 5 is a recent addition, and that's a daily active practice of mindfulness. So a daily active practice of mindfulness is where once a day you spend a couple minutes in the present moment. You're not worried about what's coming later today or tomorrow. You're not perseverating, thinking about the past. You're not thinking about other things. You're thinking about what you're doing in that moment. And that's very centering, and it's really, really therapeutic. And I've given an example recently. I have taken up shower meditation, which is weird, but I love it. I have a lifestyle of showering once in the morning, every morning. And so I sit in the shower and close my eyes and practice breathing for about 5 minutes. And when I'm done, I feel amazing. And it really, really helps my day. And so that's being 5 for 5 in your fight against MS. If you just listen to me describing 5 for 5, write down in the comments section below if you are 5 for 5 or if you're working on it, what things you're working on. So, sorry, I'm skipping around here. Let me go back. If I miss your question, please don't be upset. I will go through them and I'll probably make videos about them later. And so I'm not going to lose your question. So Jessica writes in, I finished my first year of Mavenclad in March and already had my first COVID vaccine, but it took it at my lowest lymphocyte count. Should I wait a bit longer to take shot number 2? So Jessica in Ottawa, the emerging data for Mavenclad is interesting. It doesn't seem to matter when you get the COVID vaccine as it relates to mounting a response. Let me say that more clearly. When you take the vaccine for COVID, doesn't matter as far as when you were on Mavenclad. And so that we've done studies where if you take Mavenclad and then take the vaccine soon or take the vaccine later, it doesn't really impact. And in all the scenarios that were studied, people seem to mount a really good response. So given that really cool information, I would just get the second shot when it's time. And the data would suggest that you're very likely to mount a nice response. Dana writes, Mayzent didn't affect my COVID vaccine. I have COVID antibodies now. I think that's fantastic. I am really glad to hear that, Dana. Congratulations. So Michael writes in, diagnosed. So Michael talks a lot about cardiologists, but we're going to just move along. So Janelle writes in, how do you suggest for someone who is on Rituxan and gets sick every 1 to 2 months and has to take antibiotics? Would IVIG help? So Janelle brings up a good point that when we take a medicine, we have to make sure that it's working and make sure that it's tolerated and make sure that it's safe. And so if the medicine is making you get infections, that's could be a deal breaker. And one potential solution is to put someone on IVIG. And so I've done that in certain situations. I have one specific patient that has 2 conditions. One is combined variable immune deficiency, CVID, and the other one is MS. And so if she takes Rituxan, she has lots of infections. But if she takes Rituxan and IVIG, then she doesn't. And so in that one individual, I'm currently doing that. It's a very cumbersome thing to do, though, because the IVIG is typically once a month or once every couple of weeks. And so that's a lot of infusions, but it can be done. An alternative for you, Janelle, would be to switch to a different medicine that didn't cause infections. And so there's a couple different ways of trying to approach the problem. Now, there's 157 of you that have jumped online. That's fantastic. Happy Sunday morning. We've been doing this for about 42 minutes, and I'm enjoying answering your questions. Ryan Santiago writes, I haven't had a relapse in 2 years. There are no new lesions on my MRIs, but I don't feel the same mentally or physically. Could you describe the impact of lesions in the brain on mood? So, Brian, people impacted by MS are twice as likely to experience depression and anxiety. And if you have undertreated depression and anxiety, it can color everything ugly. And it really can have a massive impact on your life, your quality of life, and even on your MS progression. And so the name of the game is to aggressively treat the depression. And fortunately, there are fantastic medicines and modalities to do that. And so that's really where I would start the discussion with your neurologist, trying to make that better, and then going back and reevaluating. Good question. So Riff Tonic writes, I'm wondering why MS symptoms are common to specific functions like vision, limb numbness, and bladder. Why isn't it more random? So I think there's a good answer for that. MS can affect anything in the central nervous system, the entire spinal cord, the optic nerves, and the entire brain. And not all of those areas are what we call eloquent. So a different way of explaining that is certain parts of the brain, if there's damage there, you're going to have a symptom. So other parts of the brain, if there's damage there, you may not know it. And I'll use the optic nerve as an example. So behind your eyeball is the nerve that runs back to connect to your brain. And it's thinner than my pinky. And so if there's inflammation of that nerve, there's no second nerve, there's no workaround. And so it's going to short circuit and you're not going to see. And so if you have an optic neuritis, that brings you to the attention of the neurologist because you're like, hey, I can't see. If you have a spinal cord injury, and that's another very common place to have lesions, you're going to come to the attention of the doctor because you can't feel your legs or you can't move your legs well, or you have bowel and bladder and sexual dysfunction, and that brings you to the attention of the doctor. Some lesions that show up in the frontal lobes or in the top of the brain go unnoticed and you don't have symptoms. And so I don't think it's that you don't have there is random spots everywhere, but certain spots elicit symptoms which make people run to the doctors, others less so. And so I think that there's a little bit of geography that's related. And that's a good question. Thank you for asking it. All right, so Unknown writes, hi, doctor. I live in extremely hot country, and all my attacks happen between the months of May and August. Does it belong to temperature, or is it seasonal by chance? So it's possible that the heat is worsening baseline symptoms. I'm not sure that heat can trigger an attack, like a brand new symptom, but it's very, very common that old symptoms are brought back out in the setting of significant heat. And I would wonder whether Ampera might be something that might help you because it can buttress against heat sensitivity. Uncle Tom and Friends writes, what do I do if I do that the MS medication, I'm not taking the vaccine? I usually get sick as a dog when I take the flu shot. So I think what Uncle Tom is saying is that if he's on an MS medicine, he doesn't want to take the vaccine for COVID. And okay, that's not what I would recommend. I would recommend doing both for two different reasons. And I think both are really, really important, but you're an adult and you get to make your own decisions, and we'll agree to disagree. I think getting sick from the COVID vaccine is way, way better than risking getting COVID. So Helen writes, thank you. You're welcome. Let's see what else we got cooking here. So Ian writes in that they're 5 for 5. Rachel's 5 for 5. That's awesome. Jessica writes 4 for 5. 2 little kids, self-care is so hard to come by. So Jessica, you're absolutely right. And with 2 little kids, it would be really hard. But maybe you could try shower meditation. If you can take a shower a couple times a week and your kids aren't in the shower with you, maybe that's the 5 minutes when you have free time to breathe. You got to be creative. Beth McGregor says she's 5 for 5. This is fantastic. Chicken Man says temp won't cause symptoms, high and low. Temp will cause symptoms. You're right. When people with MS are overheated, sometimes they have heat sensitivity and motor fatigue, and they get weak and floppy. And sometimes with people with MS are really cold, they get stiff and spasm and cramp, which is not fair. Or they could live in San Diego where the weather's just perfect. So there's some really good questions. If you guys like what's going on, definitely give it a thumbs up. Another thing that you can do, which would be fun, is to put some fire in the chat. Let's just go ahead and do a bunch of fire emojis, and let's get the entire chat filled up with fire emojis. That's really awesome. Kim writes in, I've been vaccinated for COVID since April. Congratulations. I haven't been on a DMT since losing my insurance last year. If I go on Ocrevus, like my neurologist wants me to, will the COVID-19 shot still protect me? Yes, it will. Because after you've had a successful COVID vaccine, you mount an immunity. Taking Ocrevus doesn't make it go away. Very excellent question, and I would vote to do it. So Pedro in Portugal says hi on Sunday. Hey, man, it's nice to see you. Kitty is 4 for 5, working on becoming 5 for 5. Blasphemic Atheist says stop drinking soda, sugary water. Good job. I agree that the thing to do is to avoid soda pop and fast food and heavily processed foods. This delicious beverage has 2 important ingredients, coffee and just a tad of milk, where I go, meh. That's the way I like it. So what else do we have going on here? Just ate a McDonald's biscuit, TVD, I'm sorry. So PPMS, diagnosed about a month ago, 41-year-old female, North Scotland. Ken, you're not by yourself. Welcome to this global growing online community. My name's Aaron. I'm an MS neurologist, and I put out an educational MS video every Monday. Welcome to the channel, and I hope that you can find some really helpful information here to up your game. And it's my hope that we can empower you and energize you and educate you so that you can live your best life despite having PPMS. There are therapy for PPMS, and this is not a death sentence. You can live a full life and make your MS boring. And I hope that's your goal. Welcome. Kyle D says yes to mindfulness. Hoorah. T-Mom says, good morning, doctor. Any benefits to ursolic acid supplements? Not a lot of information on that. Not something that I'm currently recommending. Elizabeth is 4 for 4. Let's see what else we got here. Beck Lacey writes, quit smoking cigarettes, then turn to e-cig. Is that as bad as cigarettes? We don't actually know if e-cigarettes are as bad as cigarettes. Anecdotally, or at least intellectually, it seems like it's less bad because you're not setting as much carbon-based stuff on fire and then sucking it in your lungs. Now, it's still pro-inflammatory, but it's probably less pro-inflammatory. And I don't know if this is something which is suggested by other doctors, but I've actually suggested for some people, they can learn to quit smoking by vaping. So what you do is you have to stop analog cigarettes. You can't use a standard cigarette. You get the vape pen, and it has a concentration of nicotine. And then each time you refill it, you drop the concentration of nicotine. So you get down to the point where you may be vaping, but you're not vaping nicotine. And then you can try to back off completely. And so I have had some patients that have done that successfully. Is it safe? Well, it's probably not safe, but it's probably safer than smoking an analog cigarette. At least that's my assumption. I like all the fire. That's awesome. If you guys are enjoying this, you can throw a thumbs up in the chat, or you can hit a fire emoji. That's fun too. Monsieur Biscuit writes, hello, Dr. Boster, big fan. Well, thank you. Got diagnosed with SPMS and can't really get a hold of it. What's the kind of future that I can expect? I'm on Ocrevus therapy. So there's not enough information, Monsieur, to really give you a proper answer. I don't have enough info to really guide you. I just want to reassure you that it's not a death sentence and that you can live a very, very full life despite having SPMS. You're on an excellent medicine. I want you to work on being 5 for 5 in your fight. And it's been my experience that patients that embrace being 5 for 5 in their fight against MS really stack the deck in their favor. The Beach 000 writes, what to do of the damage that's caused by temperature screwing up? No one knows how it influences my whole day. I think what you're talking about is that when you get overheated, bad things happen. And interestingly, your handle is the beach, which I think of like a very hot environment. And so planning out your activities, I have an entire playlist on this channel about temperature dependent symptoms, including heat sensitivity. So check that playlist out. Look at some of those tips and tricks about how to plan your day so that you optimize when you can thrive. Not going out in the heat of the day and then changing some behaviors can really make a big difference. So LM writes, I have an appointment with a urologist to check on retention. My bladder isn't acting up near as much as it has a year ago. Will it still be able to detect the problem? Yes, the urologist can. Amy Green writes in, any medication better at stopping premature mental decline? Yes. So the earliest application of the most effective DMT is our best bet preventatively of slowing brain volume loss. Some of the MS medicines can slow brain volume loss better than others. There are medicines to trick the brain into being more awake. I use a lot of Provigil and Nuvigil and Adderall and Ritalin in my practice. That can be very, very helpful in trying to help wake up the brain, trick you into being more awake and more functional. So we've been doing this for 53 minutes. There's 149 likes. I'm loving that. Thank you very much. There's 167 folks that have jumped online, and I think that's fantastic. If you like what we're doing right now, throw your question in the chat. Make sure when you write in, you write where you're coming from, because I love to read that. And make sure to give a thumbs up. So we've got another question. Do you have to get vaccinated again after Lemtrada? No. If you've been vaccinated for COVID or anything for that matter, and then you take Lemtrada doesn't remove the immunity. We've studied that, and that's really important. And so if you've got a COVID vaccine and then you get Lemtrada, you're okay. If you need to get vaccinated after Lemtrada, you want to wait at least about 6 months until your cells have come back so that you can mount an appropriate response. Jackie Stone writes, I've had meningioma on my left frontal lobe since 2004, recently diagnosed with MS. Is there correlation? No correlation. True, and unrelated. Caesar writes in, the more difficult part of the 5 for 5 is to pick the best DMT. It's not an easy decision. You're right. And so you want to pick the drug that you think is going to be the best fit for you, your disease, your lifestyle, and then you want to see how it goes. And if you turn out to have picked a drug that wasn't the best fit, then you change. The Beach writes in, it's like when it's warm, I can be cold So I'm not sure. I'm sorry, I'm not understanding that. So Pork Belly Investing writes, psoriasis related to MS? No, Pork Belly, but there's an association. So psoriasis is an autoimmune condition that affects the skin, and MS is an autoimmune condition that affects the brain and spinal cord. And if you have one autoimmune condition, you're at higher risk of having a second autoimmune condition. So I do have patients where they have both psoriasis and MS. As it turns out, there's a medicine, Tecfidera, or Vumerity. These are fumaric esters, which treat both. And so you can actually take one of those medicines and it will clear up the psoriasis and help the MS, which is really cool. All right, next question. Ken writes, the chat is full of folks. I was scared to learn about my diagnosis. It's not good. So many folks have this MS thing, but it is good to know I'm not totally alone. And you're right, Ken, you're not alone. I've been hosting this YouTube channel now for about 6 years. And as I've told folks before, I didn't anticipate the amazingness of this exact experience, this community. It is really, really cool to put a video out there into the internet and then have people from around the world write in with their comments and their questions and their opinions and their opportunity to interchange thoughts is just awesome. And you're not by yourself. There's a giant community here. I mean, heck, I turned my camera on 50 minutes ago and there's 167 of us from around the globe talking about MS. And you're absolutely right that you are not alone in this. So Ren E. Berry writes, you are my cooking buddy, my friend. I cook while listening. Well, that's cool. Today I was red lentil dye. Voila. Interesting. And now I've made lunch. That's awesome. I love lentils. I love red lentils. And I hope that you have a fantastic meal. That sounds delicious. All right. What else do we have cooking here? Kyle D writes, this is an awesome community. And I totally agree with you, Kyle. What other questions we have? A true village leader. So Andrew Jack writes, Tecfidera did wonders for my psoriasis and psoriatic arthritis. I still switched to Ocrevus because it's a higher efficacy, but treating both was nice. That's really, really cool. Guys, don't run away. I'm going to blow my nose. I'll be right back. All right. Don't run away. All right, I'm back. Sorry about that, guys. Had to blow my nose. All right, what happened while I was gone? Well, Jonah B from Glasgow said hi. I love Glasgow. I visited Glasgow twice. It's a cool town with some really fun pubs. So someone from Perth, Australia wrote in, have you heard about low-dose naltrexone? My new GP to me has prescribed this. I'm not sure if I can take it with Ocrevus. Can you help advise me? So low-dose naltrexone naltrexone is a medicine. It's an antagonist against narcotics. So naltrexone can be used to block narcotic effects. Low-dose naltrexone is a very small dose. So instead of like 50 or 100, we're talking about like 4.5 milligrams. And there's some very, very small evidence that low-dose naltrexone may help with some things in MS. The data is not amazing, but some people find that it can be helpful. Now, I don't think there's any contraindication to someone taking low-dose naltrexone and a disease-modifying therapy. Like here, you give the example of Ocrevus. So my contention is this. If you're going to take it in addition to Ocrevus, okay, I'm all right with that. Low-dose naltrexone is not dangerous. It's not very expensive. And if it's not in place of something that I know works, then I think it's on the table to discuss. Just my 2 cents. No energy during the night and early mornings. Is it true there may be a vaccine for MS? Is it in the works? So there's a lot of ongoing studies, and there's even a study recently that used the RNA technology from the Pfizer vaccine, that type of technology, so that they could do a vaccine for a mouse model of MS. And so the mouse model of MS responded to this vaccine, but we are not mice. And so, yes, there's ongoing research, but it's nowhere near prime time. Now, during the pandemic, there were some very inappropriate articles that were written with titles like vaccine for MS works and stuff like that. And a lot of people thought that it was for humans and they got very excited. when you read the article, it was just a mouse study, and it was a successful mouse study, but we need to test it in humans. Sandra Ramey writes in, hey, Sandra, a long time. Hi, Dr. Boster. I'm having a neuropsych test this week. Can you give me any idea of what to expect? I'm nervous. Sandra from Arizona and a patient of yours. Hey, how are you? So neuropsych testing is typically a battery, several hours long, oftentimes paper pencil tests. And I can give you a couple suggestions. Number one, get a really good night's sleep the night before. Number two, eat a good breakfast. Number three, arrive early. And number four, try your hardest. If you don't try, they can tell. And if you try, it's going to give you the most accurate answers. It's not a test that you pass or fail. Neuropsychometric testing is the real deal Holyfield when it comes to cognition. And it gives you the breadth and depth of cognitive functions, and it will tell you, compared to other people, how you perform. So it'll tell you, hey, compared to other women of my age and educational level, I do these things way better than the average. I do these things about as well as everyone else, and these two things I don't do very well. And if we can figure that out, we can do a lot of really cool things. We can use the stuff that you're particularly good at to help the stuff that you're not so good at, to compensate. And if we can see this pattern, we might be able to use medications to help. It'll help plan cognitive rehabilitation. And if you have a decline in work because of MS, we can demonstrate that the cognitive decline was coming from MS and not from something else. And so it can be helpful for many, many reasons. It's important not to stress about it. Just go in and try to do your best, then go home. So Jen McGraw writes in, hi, Dr. Boster. Thank you for these teaching moments. If not a new neurosymptom, not a relapse, when are old symptoms not going away an issue? And so I think if you have an old neurological symptom that's been gone for a long time and it's come back and it's lasting longer than a day, that's a risk of an attack. So you're going to call your neurologist. Or it's a pseudo attack in the setting of an infection, like a urinary tract infection or what have you. But the bottom line is you don't know what's causing it per se. You're experiencing a symptom. And if that symptom's gone on for longer than a day, then you bring yourself to the attention of your provider. That's my recommendation, so that we can try to get to the bottom of it. Maybe we need to use antibiotics to treat the infection to make the symptoms go away in a pseudo exacerbation, or maybe it's an attack and we need to give steroids. All right, multiple sclerosis calisthenics. How much exercise is too much? Can fatigue be overcome with, or is it just part of MS that you need to live with? And so exercise is so important, and we need you to exercise as part of your lifestyle. Here's my pro tip for exercise. If you exercise today and tomorrow you have a normal day, you can get up and do all your normal stuff, you didn't overdo it. If you exercise today and tomorrow you're not functional, you're in bed because you overdid it, and that was too much. So use the next day as your metric for if you overdid it or not. All right, we've been on for just over an hour. It was my goal to talk to you guys for about an hour. Let's take one more question. How do I know if my MS is active? I've only had one MRI for diagnosis, worsening symptoms, and one new one. So I think, how do you find out if your MS is going okay or if your MS is active? Really, there's three ways that I think about it. Way number one is what you experience and what you tell me, because you're a you expert. So are you having new neurological symptoms? Are you pulling away from the litmus test of life? What's going on? That's the first thing. And that's the most important thing. The second thing is what I see when we run you through what I call the MS Olympics. So a formal neurological examination or validated standardized testing, like a 9-hole peg test or a timed 25-foot walk or what have you. That's a second way that we can see how you're doing. A third way is what we see on the MRI. And so what we're looking for at a bare minimum is that you're not failing the litmus test of life and you're not having new attacks, that your exam and your neurotesting is staying the same, and that your MRI is not changing. And if those three things are present, then we're probably doing pretty good. If any of those three things are not okay, then we need to really dig in and figure out what's wrong and how we can make it better. So my name's Aaron Boster, and as always, I want to thank you for learning about MS with me. It was super fun jumping online in impromptu fashion with an Ask Me Anything MS. Thank you all for your questions. If I didn't get to your question, don't fret. I'm going to record it out of the chat, and I'll probably make a video and follow-up in the near future. Until my next live stream or my next video, or even better yet, the next time you see me at the Boster Center for MS, This is Aaron Boster saying have a great week, be safe, and take care, guys.